Next is a keynote address by Dr. Jitendra Singh Bhalla on intracameral antibiotics, fact or myth. Professor Dr. J.S. Bhalla is an alumnus of Maulana Azad Medical College, New Delhi, and was HOD Senior Consultant and Academic in charge, DDU Hospital, New Delhi, with a teaching experience of 28 years. He has special interest in cataract and glaucoma, with 53 publications in peer-reviewed national and international journals. He is a chairman, Scientific Committee, ISM, SICS Delhi chapter, President-elect AAC OIN Delhi chapter. Awarded Elizabeth Backwell Award by WOS, Dronacharya Award by UC, has received many Best Paper awards and has been reviewer of many journals. Over to you, sir.
Thank you, ma'am, for that kind introduction. At the outset, I'm thankful to KSOS for giving me the opportunity. The topic I'm going to cover is, it's a fact or a fact to start giving intraocular antibiotics. We all know that prevention is better than cure. And incidence of endophthalmitis that used to be 0.087% in the 90s suddenly jumped in the years between 2000 to 2003 to 0.265. And this was because of changes in the surgical technique as we shifted to clear corneal incision, aging population. So there was a need felt for protective antibiotics to combat this rise. What is the mechanism for intraocular bacterial contamination? One is the entry of multiple instruments may carry periocular bacteria, and second is unsutured clear corneal incision. If there is no proper architecture, that may lead to fluid influx into the anterior chamber. And this was proven by a study published in JCRS by Dr. Vasavada et al., where they found that trypan blue stained fluid in the conjunctival fornix was found in the anterior chamber up to 4 hours after surgery when the wound was not properly structured. So this, it has been found that intra-operative contamination of the aqueous humor is known to occur even during routine cataract surgery, allowing the entry of surface ocular flora into the eye. And the transient low intraocular pressures because of poor wound construction in the clear corneal incision may open and the surface fluid and contaminants may enter inside the eye. And these are the problem factor: non-use of povidone iodine, use of lidocaine jelly, wound leak, increase intraoperative time, and hydrophilic instead of hydrophobic haptics, and simultaneous bilateral cataract surgery, and also anti-VEGF injection given simultaneously increase the risk of endophthalmitis by 2 to 3 folds. These are the various measures that are prevalent. One is topical antibiotics. Some people use 1 to 3 days pre-operatively, and some use 2 hours before the surgery. Subconjunctival antibiotics, almost abundant. 5% povidone iodine preparation is a universal practice, and intracameral antibiotics are very popular in Europe. Povidone iodine, what it does is, it is only for surface decontamination, whereas we have to give antibiotics with favorable pharmacodynamic properties to have ocular protection. And it has been found that povidone iodine along with the antibiotics, it has a synergistic effect and it reduces conjunctival flora. Only the povidone iodine, if it is given, it reduces conjunctival flora by 91% for CFU and 51% for species when applied alone to the eye just before the surgery. So perioperative antibiotics have been a common mainstay of post-op endophthalmitis prophylaxis. Now only question that needs to be determined is to suggest the route of antibiotic delivery that might be critical in determining the efficacy. See, if topical antibiotics are not effective in reducing contamination of intraoperative contamination of the anterior chamber. Subconjunctival antibiotics abundant for pharmacokinetic reason. Antibiotic supplementation of the infusion fluid, again it fails to decrease contamination of the anterior chamber. Only intracameral injection of the broad spectrum antibiotic at the end of surgery is able to prevent whatever intraoperative contamination occurs during or after the surgery. And this is pharmacodynamically proven that if topical antibiotics are given several days before surgery or on the day of surgery, the concentration achieved in aqueous humor is close to 2 microgram per ml. With combined regime, again 2.16 microgram per ml. But if you give intracameral injection, you are able to achieve close to 1000 microgram per ml. Why this figure of 1000 microgram per ml is important, I'll emphasize in subsequent slides. And there is evidence by retrospective trials because of difficulty in performing large RCTs, which have proven. This was the most popular study, ESCRS multicentral study done by late Peter Barry in close to 16,000 patients, where they found that in intracameral 1 milligram cefuroxime decreased the risk of endophthalmitis by a factor of 4.92. And these were other studies, Spanish group, Singapore study, Swedish study, all found that the incidence of endophthalmitis decreased from single decimal, like from 0.5% to 0.04%, and similar was the result in other studies which were done across the globe. So according to these trials, there is change in practice pattern in Europe and US. ESCRS 2012 survey found that only 74% of the ophthalmic surgeons were using intracameral antibiotics, but later on, after publication of these studies, the practice increased. ASCRS 2014 online survey indicated increased adoption of intracameral antibiotic prophylaxis. Then 2011 AAO cataract preferred practice pattern guidelines, 2011 ASCRS, 2013 ESCRS guidelines, and 2020 Australia Surgical Antibiotic Advisory Group all have made the use of intracameral antibiotics mandatory. So now which antibiotic, for once we are convinced that intracameral antibiotic is to be given, the next question is which antibiotic for intracameral use should be. These are the various antibiotics available. One is cefuroxime, then moxifloxacin, and vancomycin. The EVS study showed that according to EVS study, 94% of culture positive endophthalmitis cases involved gram-positive bacteria, of which 70% were gram-positive staph epidermidis. And if we see the spectrum of cefuroxime, moxifloxacin, and vancomycin, we'll know the difference and we'll know which antibiotic to be used. But there are some problems with intracameral cefuroxime. One is there is lack of approved intracameral commercial formulation. I'll just take a minute more. And there is kitchen sink pharmacy approach, dilution errors leading to toxic anterior segment syndrome. And there is complete lack of activity against enterococci, pseudomonas, and enterobacteriaceae species like enterococci. Vancomycin is reserved because of its greater efficacy, and it is used for treatment of endophthalmitis. So we should not be using for prevention of endophthalmitis. And there is very severe blinding complication of vancomycin in the form of hemorrhagic occlusive retinal vasculitis, which has been reported in 23 cases till now. So we should use vancomycin with caution. Moxifloxacin is the third antibiotic which has excellent activity against both gram-positive, gram-negative, and anaerobic bacteria. Here I want to really introduce the concept of MIC and mutant preventive concentration. We all know what is minimal inhibitory concentration, which decreases the effect of, which kills about 50% of the bacteria, and 10 times that MIC is mutant preventive concentration, so that the antibiotic dose which is delivered decreases the development of the mutant resistant strains, and so there is no chance of development of resistance. So now I'll come to that figure of 1000 microgram per ml. If you inject 0.1 cc of 0.5% solution, you achieve concentration of 952 microgram per ml aqueous concentration of antibiotic, and the MIC of moxifloxacin resistant endophthalmitis isolate is just 3 microgram per ml. So why we are giving 300 times that dose? Because mutant preventive concentration is 3 into 10, 30 microgram per ml, and we are giving 300 times that dose because we want to maintain this concentration in the aqueous humor anterior chamber for close to 4 hours, and the half-life of moxifloxacin is 4 hours. So this is why we have to give this high dose, that is just 0.1 cc of 0.5% moxifloxacin. So this is Cesar Espiritu from Philippines, who injects 0.1 cc of 0.5% moxifloxacin from the side port after hydration. Then there are other methods also by Steve Arshinov and Matsura method, as he practices in Japan. So why we use moxifloxacin? No adverse reaction, no TAS, no hemorrhagic occlusive vasculitis, improved spectrum of coverage, and the most important thing is that even if endophthalmitis occur, it will be due to moxie-resistant staph, which is sensitive to standard endophthalmitis treatment of intravitreal vanco plus ceftazidime. Whereas if infection occurs after intracameral cefuroxime, it is due to enterobacter, against we have no treatment. So endophthalmitis reduction, this is the series published by, the famous series published by Dr. Haripriya Arvind in close to 6 lakh cases, and this was in about 20 lakh cases which was published in JCRS. And so although EVS study indicates that endophthalmitis can be treated, but the best treatment is not treatment, it is prophylaxis. So if we know that cataract is the maximum performed surgery in the world, so we want a technique which gives us 100% safety and efficacy. So if we do not want to see red on seeing yellow inside the eye, we should change our practice and start giving intracameral antibiotics in all our cataract surgery patients. I also take this opportunity to appeal to and request all of you for your kind support for my candidature in a coming AIO selections for the post of Joint Secretary. Thank you everyone for kind and patient hearing.
Thank you very much, sir, for the informative